to the next lecture by Dr. Jakub Pandelaki. Dr. Jakub Pandelaki is a senior consultant, eye consultant at the Department of Radiology, University of Indonesia. Now he serves as an EC member of the APSCPRR and also executive committee of the ASCI. During his early career, he completed various RR training abroad, including UCSF California, University of Vienna, and St. Mariana University in Japan. He delivers more than 40 scientific presentations to date and published more than dozens papers. Let's welcome Dr. Jakub Pandelaki. Dr. Jakub?
Yeah, please.
Okay. Dr. Jakub, you may begin
screen
presentation, and I will stop my screen share.
Okay, thank you, Dr. Pandu, for the very kind of the introduction of me. And I will share my screen. Can you see my screen?
Yes.
Okay.
Can you make it slideshow?
Okay.
Okay, perfect.
Okay. Thank you, Dr. Pandu. Good afternoon, everybody. So I will present about the imaging of peripheral AVM on vascular anomalies, especially for the peripheral AVM, not the intracranial. Yeah, because there are a lot of classification about this. As we know from the anatomy fetal period, the vascular will develop with the normal condition, but sometimes there is happen for the abnormal, like arteriovenous malformation in this case, and the second one, arteriovenous fistula. There is arterial shunting through the venous part, and lymphatic malformation, and also venous lymphatic malformation or venous malformation in this condition. I always show this slide because it's very important for us to describe a diagnosis, to establish the diagnosis more clearly. Because all of our colleagues also use the diagnosis like capillary hemangioma, cavernous hemangioma. This is this hemangioma. And also arteriovenous hemangioma, the correct biologic term is arteriovenous malformation. This is very important slide, I think. ISPA classification divided vascular anomaly in two types, vascular tumor and vascular malformation. The simple one, low flow and high flow. So AVM in this side, the branch of, we can see the high flow of the simple one, vascular malformation. As Prof. Sangyup already mentioned, there is a combined complex vascular anomaly malformation. This is ISPA classification, very useful, this vascular tumor, and this is the simple one. So how about the AVM? This is the AVM, as Dr. Sangyup already showed the slide. This is the normal vasculature in the parenchyma, and this is the nidus. There is a feeder artery, and this is the nidus, and this is the feeding artery. This is AVM. AVM is abnormal connection between arteries and vein by passing the normal interpreting capillary. The symptom usually pain, bleeding, ulceration, cardiac failure, and even cosmetic and functional problem. This is one of example. For the physical examination, very important. We can see this slide. The patient have enlarged of the right ear with the pink blue about the skin and very dilated of the pain. And if we put the stethoscope, so we can hear the bruit or trill in this case. About the clinical classification, we have Sobringer classification. This is already mentioned about the one is only warm, pink, blue, shunt or Doppler, and type 2 is enlargement, pulsation, and 3 is dystrophic, skin change, ulceration, and bleeding, and 4 is the decompensation with the cardiac failure. As Dr. Sangyop already mentioned also, this is the normal of the capillary bed, and this is arteriovenous malformation. I already mentioned about this. This is feeding artery, and this is the nidus, and this is draining vein. This is AVM. With ultrasound, in part of the lesion, show this is hypervascular lesion with many color in the lesion, with the blue and red. This is the nidus location. And this is, we can see the lesion of the dilatation of the vascular of the lesion. And the Doppler also, we can see the site of the shunting with the very low, high flow of the spectrum, and this is angiography of the AVM. CTA, yes, I already mentioned before in the part 1 of the vascular anomaly, can see the bone structure, vasculature, nidus, even the draining vein. All of the body of the lesion can see more clearly with the CT scan. This is AVM in the scalp with the feeding artery and the draining vein. MRI and MRA, like Dr. Rehan mentioned, you can use without contrast administration. So this is the AVM in the head, in the cheek maybe, yeah, the right. So we can see the nidus, you can see the feeding artery, and you can see also the draining vein into the internal jugular vein. This is tricks. Yeah, you can see part by part, face by face, this arterial face, and this is parenchymal and early venous phase, and this is venous phase. This slide show coronal T2 fat saturation or suppression image, demonstrate diffuse soft tissue lesion in the forearm arrow, and this is you can see hyperintense lesion in T2 fat suppression. And with contrast administration, sequence is time resolved. With tricks, we can see the arterial phase, the late arterial phase, and the nidus, and also we can see the draining vein. Approach to diagnosis, like a previous presentation, ultrasound is very important. Second one is MRI to see the characteristic of the lesion. Demonstrate with the pre-contrast and also after contrast. Algorithm post-contrast, we can see early arterial enhancement or minimal to moderate arterial enhancement. So we can differentiate. This is a low flow or high flow type of the vascular malformation. Other definable enhancement characteristics include the dilated pain, suspension, and arterial shunting. We can see in the time resolved contrast enhanced MR angiography. In GE machine is a tricks. Algorithm of tricks, I already present for the previous lecture or webinar. For the AVM in this site, very effective enhancement in arterial phase, especially present early dilated brain with the nidus. So we can see, we can establish the diagnosis as AVM. But if doesn't early dilated draining vein shows, so this is, we can establish the diagnosis of hemangioma. DSA. We already also explained about this modality of radiology as a diagnosis and guide for treatment with the subtraction. This is subtraction, angiography, arterial phase. This is parenchymal, early venous, and venous. This is the first blood vessel visualization on plain film. It's 1896 already happened. DSA can use not only in the brain, abdominal, and the extremity. One of case AVM in the hand, this is very hypervascular lesion. This is the nidus. We can see very high flow. And we can, this is venous dilatation with arterialization, and this is the shunt type of the spectrum. The right slide show the T1 weighted image of the hand with the plovoid lesion. This is the vascular malformation in the hand. MRI without contrast is very difficult to see the nidus. With the Doppler ultrasound, exactly we can see site of the nidus, arterial, feeding artery, and draining vein. This is DSA, arterial phase of the AVM, and until the venous phase. We can set, this is a CT angio, and this is comparison with the DSA. Cerebral angiography, what the AVM in the frontal scope of the head. And this is spatial angiography. We can see the flow between the feeding artery in the left posterior cerebral artery compared to the right cerebral artery. This is early enhanced or early with the high flow, and this is the right is the normal flow. And we can compare the treatment also with this DSA acquisition. For the physical explanation, this is right enlargement, pink blue, dilatation of vein, and with the bluey, and the CT angiogram show very clear of the arterial phase, the nidus of the patient, and also the draining vein. And this is the coronal view, early phase, and this is the exactly the nidus, and this is a draining vein. You can see the draining vein with the CT angiography more clearly also. This is 3D CT angiography. Volume rendering, we can rotating of the picture, the AP view, lateral view, even the oblique view. Classification of AVM already explained from Professor Sangyup. There is a two classification actually in the world. Professor Cho Do and Professor Yates. What the differentiation of this classification? Embolization is considered the first-line therapy of FVM. Other treatment options include pharmacological, surgical, and radiological. Already explained with Prof. Sangyu. Classification, AVM, BX, and CHODO have formulaic treatment of approach. This is CHODO classification, already explained. Type 1, very simple one, with one draining vein. Type 2 with more than 3 feeding artery, and this is non-dilated arteriovenous or nidus, and this is very dilated of the arteriovenous nidus. This is type 1. With the early phase of the angiography study, we can see the feeding artery directly to the venous. And this is type 2 of, from CHODO. This is the nidus, and with multiple feeding artery, and this is the draining vein, one draining vein. This is type 3A, more very tiny nidus. It is very difficult one. And this type 3B, the nidus and the very dilatation of the feeding artery, you can see. This is not so dilatation of the feeding artery in this case. This is type 3B. Prof. Sangyup also already present what the purpose of the classification. Yeah, according to correlation with the treatment approach. Type 1, type 2, and type 3A and type 3B. This is approach of the treatment. How about Yates classification? This is a little bit complicated compared to CHODO. This is the IV fistula. This is type 1 for the AVM. This is the direct IV fistula, not AVM for this case. CHODO type 1, same in this as Yates classification. How about the second A, or 2A, typical AVM nidus with more feeding artery, and this is one draining vein and more than one draining vein. This is the shunt to the anosmic vein, and 3 is single outflow, and multiple outflow is 3B for the draining vein. And 4 is tissue infiltrative. Yeah, same with the CHODO classification. The classification correlation with the treatment approach. Type 1, permanent occlusion using mechanical device. Yeah, ethanol can be used but small diameter IV fistula. But more huge embolant material is useful for this fistula, such as balloon, unplugged plug, etc. Type 2A, transarterial or direct puncture with absolute ethanol. Balloon and tourniquet, blood pressure cuff can be used to slow flow in the nidus. And type 2B is same as type 2A. Type 3A, single outflow of pain, permanent coiling. Professor Sangyup already have an example of this case. Same with the CHODO classification. And type 3B, transarterial absolute ethanol embolization. And type 4, superselective arterial transarterial embolization ethanol contrast combination. Direct puncture is needed for this situation of Yates classification. This is type A, like CHODO type 1 also, type 1. This is the feeding artery, and this is fistula, go to the draining vein. This is type 2A, nidus, with the feeding artery and draining vein. This is 2B, yeah, with the multiple feeding artery and one of the draining vein. And this is type 3A with multiple and one draining vein. Sorry, my internet is unstable. Type 3B, this is more, so many feeding artery, this is nidus. And this is very like a soft nidus in this type 4 of the Yates classification. We have one example for the right ear, external ear enlargement with crush, some previous bleeding in this right ear. CT angiography show the condition of the vasculature. This is feeding artery, and this is the nidus. This is angiogram, pre-embolization. We choose as Chodo 3B and Yates 3B because this is AVM, multiple nidus, and multiple feeding artery and multiple draining vein. Catheter placed selectively in the right external carotid artery, and angiography was performed. Hypervascular lesion was seen, pulling contrast and feeding artery from the right fossa auricular artery, right temporal artery, and right occipital artery. This is embolization procedure. We use VVA and gel form. After embolization, IVM, nidus of IVM disappear. Before embolization, and this is after embolization. Take-home points. Our suggestion, clinical findings is the first important thing. The second line to diagnose of the vascular anomaly, we use Doppler ultrasound. And if we want to see extensive extension of the lesion, we can do with the MR study or MRA. And for the planning treatment, we use digital subtraction angiography. CTA depend on the clinical findings. Only for the high flow vascular anomaly is useful, and also to see the extension of the lesion. Clinical finding, we use Saubinger classification. Doppler ultrasound, we should see feeding artery, nidus, and draining vein, and we can see surrounding of tissue. Chodo classification and Yates classification, we should use, and you should explain when we answer or when we establish the diagnosis in our expertise. Not only this is APM with the feeding artery and draining vein. That's all. Yeah. After this presentation, I hope all can use this classification. We can use Chodo classification or Yates classification. CTA, we can see detailed image of the blood vessel even in the body. Less time consuming and complication compared to SA, MRA, MRI, we can use tricks, sequence or enhance 3D velocity. DSA and the condensed CT we can use for diagnosis and guide for treatment. Thank you very much.